Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Caramelli, and I oversee Grand Rounds for our department. I want to encourage you to write in any comments or questions in the chat or the Q&A, and we can go through those at the end with today's presenter. There's a group of us, including Samhar Braha, who's here in this room, and Mike Walker, that work on Grand Rounds each week. We do record and then archive our presentations and have funding for the series from the Ripley Fund and the Garvey Institute for Brain Health Solutions. Towards the end of the presentation, we'll put up a link to a brief evaluation. Please complete that. That's helpful in planning Grand Rounds. Now, today's Grand Rounds is the inaugural Wayne Caton Lecture. And this is a new annual lecture that will be related to primary care psychiatry and clinical epidemiology and health services, honoring the work of Wayne Caton. Wayne was interested in clinical impact on a population level, and a lot of that was through clinical work in primary care settings. And another, similar to what we're here about today, is population-based ways to intervene, such as with suicide prevention. So we have a series of events today, a series of people speaking here, including remarks from Bobby Geiger, from Jürgen Unitzer, and then Lydia Trostiak presenting the Wayne Caton Mentoring Award. So we'll get to that in just a minute. Right now, I'll introduce today's speaker, who is Dr. Greg Simon, an investigator at Kaiser Permanente, and a psychiatrist, a staff psychiatrist there, and on faculty here at the University of Washington. Dr. Simon's research focuses on improving access to and quality of mental health care, especially for individuals with mood disorders and those at risk for self-harm. Dr. Simon, part of Dr. Simon's current work is leading the Mental Health Research Network, which is an NIMH large funded cooperative agreement supporting population-based mental health research across 14 large health systems. I'll stop sharing for now, and we'll again have a series of remarks. And for now, I'll turn it over to Bobby Geiger.
Hello, and my name is Bobby, and I was married to Wayne for many years, and through medical school and residency and on. And so I had a front seat into how he developed his work. All of Wayne's work grew out of his determination to impact social justice by improving the doctor-patient relationship. Starting from his journaling in medical school about the importance of the human power of healing that was often left out of medical training, to his work with Dr. Arthur Kleinman that focused on the medical encounter. Eventually, he and his team came up with a collaborative care model, where the aim was to deliver the most effective care to the largest number of people. Wayne was determined to do research that would support this possibility so that he could design interventions and demonstrate their effectiveness. He really loved his work because he felt it would make a difference in healing more people. It is out of this love that his work was so prolific. My personal hope is that his work is continued, stretched, and molded to continue in this endeavor. And thank you to the Department of Psychiatry for doing these starting these Grand Rounds.
Thank you, Bobby.
Well, thank you, Bobby. This is Jürgen Unitzer. I chair the department, and I'm just going to say a few things. So good afternoon and welcome to a really special Grand Rounds today. Let me start with a big thanks to Joe, to Samhar, who is actually in the room here with us today, and to Mike Walker for organizing and supporting our Grand Rounds series. To a big thanks to Bobby for being with us in person here today and for sharing Wayne with us for so many years. And then thank you to Greg for what I am sure will be an outstanding Grand Rounds presentation For those of you who don't know Greg Simon, he's one of the most accomplished and most published scholars in psychiatry and mental health services research in the world. And we really are fortunate to have him as a professor in our department. So I'm very much looking forward to his comments today. This is a really beautiful moment for me. It's a very sad moment, thinking about how much I miss Wayne as a friend and as a colleague, but also a happy moment, a moment to celebrate his work, his impact on our department and our field, and so many of us. One of the many things that I learned from working with Wayne and also from Greg is to focus on what matters, to get things done and to be efficient in doing that. I think Wayne was one of the most efficient people I've ever met. And I think if he was here with us right now, he would be thinking or telling me, okay, man, get on with this. So I'm going to stop here and I'm going to introduce my colleague, Lydia Schwastiak, who is going to introduce the recipient of this year's Wayne Caton Mentorship Award.
No, thanks, Jurgen. And I can actually hear Wayne saying, get on with it. It's really wonderful to have you here today, Bobby, and we're so grateful for all of your support. It's really fitting to acknowledge the department's 2022 Wayne J. Caton Outstanding Mentor at this lecture today. This faculty award is designed to honor a faculty member who demonstrates extraordinary support and contribution to the development and advancement of research careers among faculty and trainees in the department. And faculty members who are selected for this award really embody the spirit of Wayne's mentoring and show a sustained commitment to fostering creativity and the scholarly, professional, and personal development of their mentees. So I'm really delighted to acknowledge the 2022 Wayne J. Caton Outstanding Mentor this year is Dr. John Fortney.
Thank you, Lydia. This is a huge honor for me, especially with Bobby here. That's really special. Just want to say thanks to those who worked so hard on the nomination packet.
And thank you for all your wonderful mentorship, John. Okay.
Okay, well, good. Hello, Greg.
Hello.
Thank you, and we'll turn it over to you.
Sure. And thanks so much for inviting me. It's nice to see many of my old friends there in the room. I wish I could be there in person. It's probably a good idea I didn't plan for that since I'm now on COVID day 12. So I'm still in the mode. I'm still in the mode where I have to keep my cough to myself in my attic, which is where I am right now. But, you know, especially nice to be talking to you on a day when we're honoring Wayne, and I'll come back to that sort of at the end of my remarks. But I'm going to start, and I think I should be able to share my screen here. Here we go. And always the challenge of switching to the presentation mode and seeing if I get the right screen to show. So I'm hoping you are seeing the screen that has the slides and not the notes.
Yeah, you're good.
Okay, thanks very much. So I'm going to talk to you today about population-based suicide prevention and focus on a large pragmatic trial that my colleagues and I conducted several months ago, but talk both about that trial sort of in context. And the important point is the last part of that title, the where do we go from here? Some disclosures, the work I'm describing is supported by cooperative agreement from NIMH. I personally am an employee of Kaiser Permanente, so that may be relevant, but I don't have any other relevant financial interests or disclosures, and I won't be talking about any off-label or investigative uses of commercial products or devices. I'll describe work that's done by a very large team, and these are only some of the people. The pragmatic trial I'll be describing was conducted at KP Washington, 2 other regions of Kaiser Permanente and Health Partners, and these are some of the sort of key colleagues at those places. So I'm going to start with the ending. You know, the trial I'll describe, the results have already been published, so there's no suspense. We studied whether 2 low-intensity outreach interventions could reduce risk of self-harm or suicide attempt among people who report frequent suicidal ideation. Not only did we not find that either intervention reduced the risk, we found that one of the interventions may have actually increased risk. So I'll talk a lot today about how we understand that and where do we go from here. But now back to the beginning. You know, we started this work on this trial actually probably now about 9 years ago, when we'd done a lot of work looking at the routinely administered PHQ-9 depression questionnaires that were being used across our health systems, and found that people's answer to that 9th item of the PHQ-9 actually identified people who were at significantly increased risk of self-harm or suicide death. Looking around, we said, what do we have to offer those people? And we actually, at that point, had pretty good evidence for some specific interventions that worked under, and I'll underline and come back to that, specific circumstances. Dialectical behavior therapy developed by our own Marsha Linehan at the University of Washington. Cognitive behavior therapy adapted for suicide prevention, which is a similar but somewhat different approach. And then there were various trials of care management interventions, many of them modeled after collaborative care that were attempting to not only improve treatment of mood disorders, but reduce suicide risk. So we settled on testing two sort of candidate interventions. We needed interventions that could be delivered at very broad scale to large numbers of people. So we developed a dialectical behavior therapy skills training intervention delivered primarily online, and I'll describe that to you in a minute. And then a sort of care management intervention that was very much based on the concepts of measurement-based care and sort of proactive outreach. And our study question was whether health systems should implement either of those programs to reduce the risk of suicidal behavior among people who report frequent suicidal ideation when they fill out one of those PHQ-9 questionnaires. This study was conducted at 4 large health systems that are part of our mental health research network. The general design was that we use the records data each week to automatically identify people who'd made a visit, filled out one of those questionnaires, and reported that they had thoughts of self-harm or suicide more than half the days or nearly every day. People were randomized as soon as that questionnaire result was received, people were automatically randomized to 3 groups, either to continued usual care, meaning we never contacted them, but they received whatever care their clinicians would have ordinarily provided. They were being offered, and I underline the word offer, this care management program or offered the skills training program. These interventions were offered to people in those groups for up to 12 months. The outcome of the trial was either death by self-harm, a fatal or non-fatal self-harm, over 18 months after people were randomly assigned. And we started off with a target sample size of 19,000 people, or about 6,500 people in each group, based on our expectation that the event rate, the proportion of people who actually had a self-harm event over 18 months would be about 3.75%. So that's how the power calculations worked out at the beginning. Both of the interventions began with an invitation process that's probably really important to understand this trial, and it was similar for the 2 interventions. People were invited primarily through online messaging through the electronic health record, the EPIC record that many of you are familiar with. So people received an outreach message, which included expressions of caring and concern modeled after the caring message interventions that some of you are familiar with. There was a description of the specific program we were offering. So people were the brief description of the care management program or the online skills training program. There was a sort of, you could say, abbreviated informed consent information. And we had to say, this is part of research. Your participation is voluntary. You're free to decline or withdraw at any time. People would receive that initial invitation. If they didn't respond, they would get a reminder after a few days, which would either be by secure message or, if they had not read the message, by phone. People were invited for up to 3 rounds. If people didn't respond to that first invitation positively or negatively, we invited them again 4 weeks later, and then again another 4 weeks later, 8 weeks altogether. Those who didn't respond after these 3 rounds of invitation, we didn't contact them again, but they could certainly sign up later. They could respond later and say, I want to participate. But this is, something we worked out over time in terms of an outreach approach that we thought was sort of reasonably persistent, but not to the point of being too intrusive or bothersome. But, that's a fine balance. So I'll describe, after this invitation process, sort of what the 2 interventions offered for people who said, yes, I'm willing to participate in that. The care management intervention was intended as a supplement to people's existing outpatient care. The fundamental idea here was that people need to continue to get effective mental health treatment, and care management should be designed to get people engaged in or keep them engaged in that treatment. It very much incorporated elements of collaborative care or care management interventions. The idea of systematic outreach and measurement-based care. Here, the measure was the Columbia Suicide Severity Rating Scale, and the idea being that the intensity of care people receive should be related to their need as measured by the Columbia. We had a sort of, very much like collaborative care models, we had sort of a measurement-based or risk-based recommendations for frequency and type of outpatient care, using motivational enhancement and care navigation type interventions to help people stay engaged in care, communicating with their treating typically outpatient mental health providers. The intervention was delivered primarily by secure messaging through the electronic health record, but sometimes by telephone when we weren't able to reach people or they were not able to communicate by secure message. We had a sort of higher intensity program when people had a high score on the Columbia, and this whole activity continued for up to 12 months. The skills training intervention was also intended to supplement and not replace people's care. The fundamental idea here was that people who are at high risk for self-harm need something specific. That is, they need those dialectical behavior therapy or emotion regulation skills. And the idea here was to develop a program that could introduce and provide some brief training in those skills at large scale. So we developed an online program that focused on 4 specific DBT skills listed here. Each module in the program had a brief sort of video description of what the skill involved. There was video instruction from clinicians, and very important, lots of video examples from people with lived experience of suicidal ideation or self-harm about how the skills had been helpful to them. People were asked to commit to specific practice. There were homework pages to create homework assignments. It was supported by a coach, and we use the word coach instead of therapist because the role of the coach was not to take over as a psychotherapist, but to encourage using the program and to serve sort of, you could say, as a tour guide. So the coach's role was to encourage people to visit the program and use it, to remind people if they hadn't visited in a while, to reinforce when they did visit or especially when they entered homework assignments. This whole reinforcing activity, again, continued for up to 12 months. The primary outcome of the trial was a self-harm event, a suicide attempt, or an injury or poisoning that was coded as having self-harm. The suicide deaths or self-harm deaths were identified from linking to state mortality data, and non-fatal events, typically presenting in emergency departments or hospitals, were identified from the health system records. We had a sort of a process of identifying events that were definitely coded as self-harm, and then also identifying what we thought of as sort of potential events. And these would be injuries or poisonings that might have been coded as so-called undetermined intent or even accidental intent, but were the kind of things we thought we should look at. So there was a separate sort of chart review process of looking at the records of those events to say, was that really a self-harm event? It was a time to event analysis, so people were censored at the time they disenrolled from the health system or died from a cause other than self-harm. We had 2 secondary analyses that I'll come back to later because they're very relevant to how we interpret the trial. One is we looked at a narrower definition, that was self-harm events that led to death or hospitalization, more serious events. And then there was a broader group that looked at all of these potential events, even if we didn't confirm them by reviewing the full text records in the electronic health record. Blinding is a sort of complicated question in a study like this. Usual care participants were never contacted, so they were, you could say, blinded. They were unaware that this study was going on. Obviously, participants assigned to either of the intervention were not blinded to the offer, but they were not aware that there was another intervention. So we didn't tell people assigned to one group, there's this other group that's getting something different. The outpatient clinicians who provided ongoing treatment were obviously aware. That was one of the whole purposes, especially for the care management intervention. They were aware that people had been offered this intervention. The outcomes were generally identified by emergency room and inpatient clinicians, and they were not notified about this study or that people were in the study. It's possible they could have been influenced because there might be a note in the record if they were seeing someone in the emergency department that someone was participating in this program. This was very much a pragmatic trial, and that may be a term familiar to many of you, but to sort of focus on the design features that we would say makes it a pragmatic trial. We were identifying people automatically from their existing records. We were not sort of recruiting participants in a traditional sense. There was a sort of broad eligibility criteria. We didn't assess eligibility other than to exclude people, and I didn't mention this, people who had in their record a clear indication that they had dementia or a serious developmental disability. People were randomly assigned as soon as they were eligible. We did not ask people to volunteer. We did not ask them whether they wanted either of these interventions, but that was the whole point. We were interested in, should we offer these to people? And the fact that some people might not want them that's part of the question. We were comparing these interventions to usual care because I think that's the policy question relevant to the health systems. Participants were free to decline the interventions we're offering or withdraw at any time. We assessed the outcomes from the health system records. We didn't call people up and ask them about self-harm events. We can talk about whether that would have been a good idea. And the analysis is, you could say, sort of a radical intent to treat analysis. So we analyzed the trial according to how people were originally assigned or randomized, regardless of whether they participated in the interventions at all. This is a CONSORT diagram. I won't go into the details, but as you can see, we ended up identifying 18,800 and some people who were randomly met our criteria and were randomly assigned, about 6,200 in each group. There were a few people in each of the intervention groups who were not offered the interventions. That would typically happen when one of our intervention clinicians was about to send a message and they would see something in the record that told them this is not appropriate. For instance, we had not caught it previously, but they could see in the record that the person was severely demented or was in hospice care or some other reason why it would be inappropriate. Those people were still analyzed according to their original assignment, but we did not contact them to offer the interventions. And then you can see in those bottom boxes, all the people who are randomly assigned are included in the analysis, but there is some censoring. Some people are censored because they died or from a cause other than self-harm or disenrolled from the health plan. Okay. So this is the sort of table one, the description of the study sample. We don't need to go through all the rows, but I think the main point is these are the kind of people in a big health system who would be receiving mental health care and report that they had frequent thoughts of death or self-harm. Sample is about 2/3 female, predominantly middle-aged. The race and ethnicity distribution reflects the health systems where we were operating. About half of the people were identified from a mental health specialty visit and about half from a primary care visit. About 2/3 of them on that PHQ-9 item 9 questionnaire, all of you are probably very familiar with that, scored 2 on item 9, saying they had thoughts of self-harm more than half the days, and about 1/3 said they had those thoughts nearly every day. The diagnoses of depressive disorder and anxiety disorders were common. Smaller proportions of people with diagnoses of other substance use disorders or more severe mental health conditions. About 10% had had a mental health hospitalization in the last year. About 15 to 16% had had a mental health emergency department visit in the prior year. So first, what did we find about the people's participation in an uptake of these interventions? It was relatively low, but to be honest with you, we were not that surprised by that. So what you see here, as we saw in a few slides ago, there were a small proportion of people in each of these intervention groups who were not offered the intervention. The proportion who actively declined, when we contact them, they said, no, thank you, I do not want to do this, was higher in the care management intervention than the skills training intervention. Our interpretation of that was that the initial ask was a bit more there because it was, I want you to participate in this assessment and answer my questions, as opposed to please just visit this website. There were about 40% of people who did not respond after these 3 rounds of invitation. There was no response at all. This is now important to recognize. You could consider these people in some ways they never received the treatment, but what they did receive was they received at least 3 messages that said, we are concerned about you, we care about you, we want to make sure you get the help you need. Which is very much the content of caring message interventions, which at least in some settings have been thought to reduce risk of self-harm. Of the people who engaged, what you see here, and this was not surprising, engagement fell off very quickly in the skills training group. We weren't really surprised by this because the online intervention was relatively brief. People could work through all of these modules relatively quickly. So most of the people who started were not actively using the program after about 3 months. There was longer term engagement in the care management intervention, which was sort of by design because we kept calling people and reaching out to them. So the sort of headline, which I'll show you in the next picture, is, what happened in terms of the rate of self-harm events. So this is the Kaplan-Meier plot showing the cumulative proportion of people who experienced a self-harm event over 18 months. So that's 548 days at the bottom, and that y-axis goes up to about 4%, which is what we had predicted. Now, when we first saw this graph, if the colors had been arranged in a different way, this would have been exactly the result we hoped for. If the colors were that green group was usual care and there was a lower risk in both of the interventions, that was the result we hoped for, but that was definitely not the result. What we're seeing there instead is that there's actually an increased risk in those who are offered the skills training intervention, and those who are offered the care management intervention really not different from the usual care group. Believe me, when we saw this, we had a lot of questions. To be honest with you, our first question is, did we mix up the labels on the groups? Because this was a surprising result to us. And believe me, we looked into that pretty closely, and that was clearly not the case. So then more sort of substantive scientific questions. Was there some bias in how the outcomes were measured that might have resulted in this finding? Or if we really believe this is the case, how and where and what way could offering people this skills training intervention have actually increased their risk? So about that second question, biased ascertainment of the outcome. It's certainly possible that exposure to these interventions might affect people's behavior. For instance, people might be more likely to seek health care after self-harm. They might be told, we might be normalizing this, and this might not be a bad thing if people had a self-harm event and were more likely to go to an emergency room. Or we might increase the likelihood that a self-harm event would be revealed or detected. People might be more likely to report to someone in an emergency room or hospital that actually was an intentional self-poisoning rather than an accident. To look at this is where these secondary analyses came in. This question about, change in likelihood of people seeking care. We looked at self-harm events that led to death or hospitalization, assuming that they were less discretionary. People might be, less likely to make a sort of discretionary decision about care seeking for more serious events. And this question about sort of disclosure or recognition, we looked at these potential events and included those in a sort of broader outcome specification. Potential events included, for instance, things like, the obvious things, wrist and forearm lacerations, poisonings with psychotropic medications, even if they were called accidents. I know certainly we got questions that, well, why didn't you just do surveys? And, that would deal with the bias question. We can talk about that more. My view is surveys would definitely not deal with the bias question because, then certainly people might be more or less likely to report having self-harm events if they participated in one of these interventions. Our view, and we can talk about this, is what was ascertained in the normal operations of healthcare is probably less biased. But so what did we see in those secondary analyses looking at these things? This is the analysis of more severe events, those leading to death or hospitalization. You see the same picture. The overall rate is lower because these are a subset in more severe events. And there's no longer a statistically significant difference between the DBT skills, the group offered DBT skills and the other groups, but the pattern is really the same. And then this is looking at the broader outcome definition when we add those sort of potential events. And the general pattern is the same. The difference between the groups may be smaller because we're basically introducing sort of more noise into the system, but we're not seeing any different and certainly not any reversal of this pattern when we look at these alternatives. So looking at these, I think we really had to say this looks real. It really does look like, being offered this skills training intervention increased the risk of self-harm in that group, and that the care management intervention, at least given the relatively low engagement, was not effective. We conducted a number of subgroup analyses, and I want to be clear, the purpose in looking at subgroup analyses is not to say, oh, let's try to find some place where this worked. Let's try to make the bad news go away. At least in our minds, the purpose of the subgroup analyses is at this point to say, if it looks like we actually may have caused harm, where did that occur? But we didn't find that. When we looked at across the different study sites, across the different years, for people who did or did not have specific diagnoses, for people who had sort of more indications of more severe risk, that we didn't find significant, you could say, heterogeneity of treatment effects or interaction effects. When we looked at what services people actually used, what we saw there was not that surprising. What we see here is that the goal of the care management intervention was for people to be more engaged in outpatient care, and it did not do much. You could say that's the upper left panel, where we see that we didn't see much of a difference in people's likelihood of making mental health outpatient visits over 18 months. We did see, if we look at those two right-hand panels, in terms of emergency department visits or inpatient stays, They bounce around because those are less common events, but we actually see higher rates in those offered the DBT skills intervention, which is not surprising. It's consistent with the primary result. So one other thing we looked at was, if we look at how people participated in the interventions related to what the risk or what the outcome events were. And I want to be really clear here in showing you this, why one should do something like this and why, at least in my opinion, one should not do anything like this. The so-called sort of per protocol or as treated analysis, to use the term of art, is something that to my mind is often misused. Because especially in a case like this, what we should not do is to say, let's look at people who participated or received the intervention, and let's take them out of the intervention group and compare them to the control or usual care group. Because of course, there is no way we can identify those people in the control or usual care group who would have declined an intervention. So that, at least in my view, any such comparison is sort of irretrievably biased. So what we're not doing here is making any between group comparisons, but what we are doing is looking within groups. So we're looking at both of the intervention conditions and saying, what was the rate of self-harm events according to how or if people participated? There are a lot of colors on those graphs, so let me step you through that. One of our first questions was those people who actively declined and said, I don't want to do this. Was there something bad about that? Were we sort of causing harm by bothering those people? And the answer was really no. Interestingly, that's the brown line at the bottom. The people who actively refused had actually the lowest rate of self-harm. On the other hand, if we looked at the people who sort of engaged only briefly, these are people who said, yes, I want to do this, and then left it, only within the first 3 months. That's the orange line. What we see there is that group clearly had higher risk in both interventions. We did not observe an increased risk overall in the care management group, but we do see in both groups that orange line is clearly above the others. The blue line is a bit hard to interpret. Those are the people not offered intervention, and it's a very small group, so that probably is an unstable estimate. But this is actually a significant difference, that those who only briefly engaged in the intervention had the highest risk. With the caveat that, we're now sort of post hoc after the fact trying to explain something, but we want to try to explain it. My best explanation or my best understanding of why is it that this phenomenon of engaging and then disengaging appeared to, those are the people who had the worst outcomes, may be a disappointment effect. What we may be observing is that people whose hopes were raised, who said, this is going to help me, and then found it didn't, that may have been our problem. So taking a step back and trying to sort of put this in context, how do we interpret this study in light of sort of the broader evidence? It's important to understand how people in this sample were different from many of the previous trials, some of which have actually found some effectiveness for interventions, whether those are the dialectical behavior therapy trials, cognitive behavior therapy trials, or even more recently, trials of ketamine for people who have severe depression and are high risk for self-harm. Here we're looking at a much wider range of people, a much wider range of risk, people who are at very high risk and people who are at only moderate risk. And probably more important, we're looking at people who were not at the beginning, we certainly were not limiting this to people who were accepting or even considering participating. The whole point was, let's try reaching out to people who may not even want our interventions, because those are the people we may need to be most concerned about. Thinking about this care management intervention versus some of the more, you could say, collaborative care type or effective care management interventions, this program was relatively lower in intensity, but maybe more important, we were care managing in a very sort of generic or heterogeneous way. What we were not doing, in contrast to some collaborative care intervention, was care managing toward a really specific treatment. We were not, for instance, saying, as in collaborative care for depression, we are care managing to increase the effectiveness of antidepressant medications, which are effective, or psychotherapies, which are effective. It was more care management to keep people engaged in general purpose mental health care, which may not be a specific enough intervention. And then when we think about this skills training intervention versus more traditional dialectical behavior therapy, obviously it was much lower in intensity, had a narrower range of skills. And maybe very important, there was no group component, which may be a key issue. In thinking back about our sort of general strategy in this area, one of the questions we ask ourselves is, did we skip a step in the process? And that's always easy to ask after the fact. We can look back and say there are trials of effective interventions for suicide prevention. The trials of dialectical behavior therapy or cognitive behavior therapy include samples of a few hundred patients, typically people who are more motivated or engaged, who want to participate in such a trial or even want to receive those interventions. The interventions are more intensive and more standardized. And we made a relatively big leap, going to samples of tens of thousands of people, taking all comers, even those who had no interest in the intervention at all, delivering interventions that were sort of lower in intensity and more variable. And what we found was that was not effective. So the question, I think, is, was there something, or even now, is there something in between that we might have considered instead? So what's happened in the meantime? When we say, while we were doing this trial, what other things did we learn about this general area of population-based or broad-based suicide prevention? Interestingly, we've done work and others have done work about more accurately identifying people at risk. We now have sort of these prediction models or machine learning derived risk predictions that can much more accurately identify people at risk. Maybe if we had used something like that, we would have been able to more accurately target the people we really needed to help. There is some evidence about screening and structured follow-up in emergency departments. But I'd say since that time, there's been really mixed evidence regarding caring contacts. Many are familiar with Kate Contois' text messaging trial, which I think, did not find some of the same benefits as previous trials of caring message interventions. So where are we going? We have a few next steps in progress. One of those, we're actually conducting now a large pragmatic trial of stepped care suicide prevention interventions for adolescents. This is led by Greg Clark down at Kaiser Northwest in Portland and involves some of our other mental health research network sites. We're sort of, you could say we're doing some of the things that I just mentioned. We're identifying high-risk adolescents using one of these statistical prediction models so we may be able to more accurately focus. It's all doing the same kind of, and I didn't use this term earlier, a Zelen design or this randomized offer. So it's still very much in the mode of let's reach out to people who did not step forward and volunteer. But the intervention is definitely more structured and more intensive. It's a stepped care intervention that does include care management, but includes really a, you could say, full fidelity or full strength dialectical behavior therapy group program. We're also interested in more, you could say, universal prevention interventions or broad-based interventions, specifically focused on how do health systems do things to reduce access to lethal means of self-harm. Looking at research on promoting safe firearm storage. There's a program called Lock to Live that some of you may be familiar with. And one of the things we're just getting started on is interventions for safe packaging of high-risk medications for high-risk people. You may be familiar with the evidence in the UK that when paracetamol or Tylenol, as we call it, could only be dispensed in blister packages rather than bottles, it actually reduced both the frequency and the severity of Tylenol overdoses for self-harm. We're also interested in sort of more specialized pharmacotherapy interventions, increasing uptake of clozapine, which, as you may know, that's a very specific and specific targeted population, but is the only medication with an FDA-approved indication for reducing suicidal behavior in people with psychotic disorders. And then looking at buprenorphine as a suicide prevention strategy in people specifically who have opioid use disorder. So what I want to do sort of to finish is take a step back and interestingly, since, we're honoring Wayne Caton today, to talk about some things I learned from working with Wayne. And in some ways I'm curious what people think about this. I'm going to do a little bit of revisionist history, which I think I have the right to do since I'm an old timer. I can say I was around at the beginning. So the mythological development of collaborative care, the history which is often, I think, believed, is this. These are what I consider, at least the names I use for those trials that began back in literally 1991. The original sort of, well, actually one of them began in the 80s, but all of these trials, and I think the mythology or the mythologized history is that onward and upward. Continuous progress, everything's successful, and everything gets better. The revisionist history, but I think I know the accurate history since I was there, is it wasn't really that way. Lost in history is the fact that the very first pragmatic or effectiveness trial, clinical trial done by, Wayne's group and Michael von Korff and Elizabeth Lin and other colleagues at then Group Health, was the idea that a psychiatric consultation note for people who were high utilizers of healthcare and had significant anxiety and depressive symptoms, a consultation note telling the primary care doc what they did not know would solve the problem and people would get effective care and would do better. And that did not work. What that led to, I think, was a really important advance. The recognition that this is not fundamentally a knowledge deficit. That's where collaborative care was really born out of the failure, in essence, of that first trial to say, we need systematic programs to measure outcomes, to make sure that people are getting the care they need and to follow up on that. Progress, progress, progress. The next sort of bump in the road was a trial that was looking at collaborative care, sort of two forks for people with more chronic depression, but also collaborative care for people for relapse prevention, for people who started treatment in primary care and had a really good outcome, achieved remission, and a sort of collaborative care relapse prevention program. The story there was not that it did not work, but that it was not necessary. And it was interesting. This was part of a whole, to my mind, remaking of thinking about depression, that the idea that people who receive treatment for depression and achieve complete remission and do well actually have a pretty good outcome. And that's probably not where we need to focus our resources and energy. And then interestingly, that trial about collaborative care for depression and diabetes was based on the concept that if people who have co-occurring depression and poorly controlled diabetes, if we just provide depression treatment and get depression under control, diabetes control, and therefore risk of diabetes complications or bad cardiovascular outcomes will naturally just get better when depression gets better. And it didn't. What that led to was another major advance, which was this idea about multi-condition collaborative care, a measurement-based care simultaneously focusing on multiple chronic conditions, which I think was a significant advance to the field. So my message, I think, is I think sometimes maybe that mythologized history may not serve us well because it's the idea that everything is always right. When the truth is, and this is my revisionist history, we learned the most from the things that did not work. I'm hoping, given that the big trial I just described to you clearly did not work, we learned something from that and that we will maybe be able to have some success with some of these future efforts. So I think, my last slide, I'm going to stop there. I don't think I need to come back to this slide, so I'll stop sharing my screen here. And looking, I realize I don't know how you do questions, whether it's raise hands or chat or what.
No, Greg, thank you. Very interesting to hear all the details of this trial, interpretation of the results, an appreciation of the history and description at the end as well on major clinical trials that many of us are familiar with. Thank you for this presentation. I think there's a few questions that have come in. And one gets right to the beginning of the intervention that you selected. Can you talk about the specific skills that were selected in the DBT skills arm?
Yeah, we worked with actually Marcia and some of her team, and one of my colleagues whose name was on there, Ursula Whiteside, was actually worked in Marcia's, in Marcia's group, in Marcia's lab, and she was part of our team at the beginning. And the idea was that we can't do everything. What do we think are the sort of most important and in some ways most basic, the building blocks? Now, of course, we know better. And when we've talked to people about that, and if we're doing this different, we might choose some different things. But that was at least at the time. And this really was, trying to think, those decisions were made probably about 7 or 8 years ago. That was what seemed like the right thing to do at the time. And I think, going back, to me, one of the interesting questions is not just which skills, but how, by whom. The idea of skills without a group component, to me, that's a really important distinction.
Well, I'd like to encourage any participants to write in questions either into the chat or Q&A. And yeah, no, okay. I'm wondering if anyone in the room has a question. Okay, Greg, I'm wondering, was there recognition or advice about maybe concurrent psychiatric disorders in this trial, or was that not the case?
Well, and that was sort of what I meant when I meant care management toward, but more sort of generic or non-specific care management. So certainly the idea was for people in the care management group, the idea was, to in some ways keep pushing them back toward effective outpatient care. When people, were not receiving, appropriate care, and our guidelines were more based on risk of self-harm. So, we had sort of a protocol that said, okay, if someone's Columbia score is 3 or higher, they really need to have an appointment scheduled with their outpatient clinician within a certain time. And if they don't, let's try to make that happen. But we were not dealing with people, focused on any specific diagnosis, be that depression, anxiety, bipolar disorder, or whatever. And so there was not sort of care management or measurement-based care focused on specific treatments. And I think, and of course this is after the fact, but it's my, this is my interpretation. I think if we look more broadly at care management interventions, care management interventions work when we have a specific effective treatment to manage people towards, and they don't really work when we don't. So many of you may be familiar with some of the more generic sort of, Medicare demonstration project care management for people with all kinds of diverse conditions. They didn't do much because there wasn't a specific thing they were focused on. Collaborative care interventions for depression and anxiety are really focused on, there were effective treatments for those conditions. Many, many years ago, along with Jürgen and some others, we did some work on collaborative care interventions for bipolar disorder. And actually, we did a trial of that, and Mark Bauer did a similar trial in the VA. Very similar findings, and to me, it was instructive that care management interventions to improve care of bipolar disorder were clearly effective for reducing risk of mania or severity of manic symptoms, but not so much for depression. Probably because for manic symptoms, we have treatments that really work. And for depression and bipolar disorder, we may have better treatments now than we did back then. That was more than 10 years ago, but they still aren't that great. So managing people toward, a generic or non-specific or especially relative treatments that don't have very good effectiveness is not going to make a difference.
Thank you, Greg. I appreciate that response. There's a question about the skills training videos. Were they the same videos from Now Matters Now?
Very similar. There were sort of more. Now Matters Now is a program that Ursula Whiteside, our colleague, developed, which makes some of these videos available. And we used, some of them were overlapping, and there were some. Now Matters Now has some new ones that were not used in our trial, and our trial had some sort of more detailed ones that are not part of that. But the general scheme is the same. Mm-hmm. Feedback from participants on the skills program. This is I have maybe a long answer to that question because it's a really important question. The difficulty there is that most of the feedback we got about these programs was positive because we got the feedback from the people who kept participating in them. We did not get the feedback from the people we probably were most concerned about. We obviously got no feedback from the people who said no thank you. We got no feedback from the people who never responded. And we did not get much feedback from the people who joined and then left. Because when people joined and left, we certainly did make repeated efforts to re-engage, and we made efforts to re-engage either until they told us, leave me alone, or if they just didn't respond to any of our messages. And this is, I think, the real challenge in this type of work is those people you would most want to know what happened are probably the people who don't want to talk to you anymore.
Yeah, there isn't a question that came in about distinctions between DBT brief interventions compared with standard DBT. With the absence of group treatment, for example.
Yeah, no, I think that it's a really, Yeah, it's a really key question, and clearly, one of the, if you want to say what's the briefest summary about the DBT skills intervention, I'd say don't do what we did. We would not do that again, obviously. But interestingly, and this is one, I'll say this because I think it's important to say, this trial was conducted sort of mostly pre-pandemic, kind of actually right up to the pandemic. I mean, we didn't plan it that way because who knows that was going to happen. But the last bit of the sort of 18-month follow-up window for participants in this trial happened in, right up until actually a little bit past March of 2020. So this was all pre-pandemic. But we were seeing the results of this trial, first seeing those results in late 2020. And it was interestingly, I think in the health systems where we worked, but also in the broader community, there was this whole idea about what are we going to do about this sort of, the mental health fallout of the pandemic. There was a big concern actually about increased rates of depression, of even suicidal ideation or suicide risk. How are we going to serve all these people who need help? And actually, we were actually hearing from some of our health systems, what we really need are some online things to teach people DBT skills and provide some coaching. And in some ways, maybe I'm being a bit defensive to say, it was what everybody thought was the right thing to do if you really want to provide sort of at a population level, at least some little thing that might be helpful. And we were seeing the results of these trials. And I remember having some challenging meetings with some of the people in our health systems when they were saying, we really need to do something about this. Let's slap together a program and do this thing. And we said, don't do that. It's a challenge to say, I think, if we want to do something effective, people probably need real treatment that's actually effective. And half measures not only may not be helpful, but there may be some situations where half measures are actually alienating or disappointing to people.
Greg, you may have seen the next comment is from Elizabeth Lynn regarding the revisionist history of collaborative care. Which, if you had more to comment on that.
I didn't check with, I talk to Liz all the time, but mostly about the crab that that Dan, her husband, catches and gives to us, which is a great gift, Elizabeth. But I did not check with her about this revisionist history. I'd be curious if she sees it that way too. She was there even earlier than me.
So the next question gets to what you were posing about what health systems might adopt to support individuals at risk for suicide.
Well, I think, what certainly we are not doing, low intensity DBT skills offered online supported by a coach. We're saying don't do that. Where there are exactly some of these things that we talked about. We're saying, how do we address access to lethal means? How do we identify people, especially who are at risk of firearm self-harm, because firearm self-harm is almost always fatal, unfortunately. We've been looking at, as I said, about overdose prevention. I could put in the chat if we have time. One of my colleagues, Jen Boggs, wrote a paper that's really, I think, important and concerning about, how often when people have a self-harm overdose, was that medication dispensed to them by our health system within the last year? And the answer is most of the time. So that's an obvious target for doing something. A big focus on safety planning. Which is sort of related to access to lethal means, but there are other aspects to safety planning. So those are the big things that we're focusing on now.
Greg, a related question about sort of the closed system within a health system such as Kaiser. Does that influence interpreting the findings in some way?
Yeah, I mean, in terms of sort of access to care, this trial was conducted at a time when access to mental health care in our systems was reasonable. And, when we say, that graph I showed that, gosh, people pretty much dropped off in terms of receiving outpatient mental health care. The issue there was not that, services were unavailable. It's that people, did not want them or did not find them helpful, which is unfortunately true about mental health care for a lot of people. I would not say in 2020, 2021, because, as everybody knows, access to mental health care during the sort of pandemic and, even through 2021 has been terrible all around. So that's a big, big issue but I would not put that up as an explanation for why people were not getting that much outpatient mental health care in this trial, because this was before that sort of access crisis.
Greg, another question came up about low intensity interventions potentially being iatrogenic. Would you advise people to say sort of not to offer that, number one, and number two, does it seem maybe that accepting a low intensity intervention might be sort of kind of a big opportunity cost? The person might see that as treatment and might not accept other treatments.
Yeah. Well, I remember, when we saw these results, obviously one of the first people we shared them with were the leaders of the mental health leaders in these health systems, to say, you need to know this. And as always, these are not researchers, but they're pretty smart people and often, have even better than researchers a way of getting right to the point. And I remember, one of the Colorado, medical directors saying, that's really interesting. He said, my sense is when you look at what people say about DBT, he said, we said about CBT, cognitive behavior therapy, he said, seems to be evidence you can sprinkle a little bit of cognitive behavior therapy over a lot of people and it does at least a little bit of good. Doesn't look like that's true for suicide prevention. I said, yep, you're right. And so I would not say, that I would say, low intensity interventions, certainly in terms of reducing, especially, less severe symptoms of depression and anxiety. We've got pretty good evidence for that. I would not be opposed there. But, sort of low intensity interventions for, specifically directed to and maybe focused on reducing risk of self-harm, I would not do that again.
It's a very important distinction. I appreciate your phrasing it that way. Yeah. Greg, we're just about at 1 o'clock. I wonder if you have any kind of wrap-up comments. There is a final question that came in, but I think given that we're at 1 o'clock, we should probably wrap up. And
Yeah.
I do want to thank you again for presenting today. And here we are at the first, the inaugural Wayne Caton lecture, and hearing the history of collaborative care as well, and the detailed results and methods of this trial, and very sophisticated ways of interpreting results. It's very informative, and thank you. And I see Jürgen is here and may have a comment.
No, just thanks again. A great presentation and very, very well done work, and very important, always has been at least as important for us to know what's not good, what's not working, as occasionally something works and then we make a big fuss about it, right? So thank you.
Yeah, you're welcome. Thanks. Good to see all of you, and good to think about Wayne. Thanks for the opportunity.
Okay, thank you. Bye.